Okay, 7:02, and we're going to start the recording. It's November 14th, and this is lecture 2 from, I believe we're in module 6. So let's get rolling. Yeah, okay, there we go. Want to be sure y'all can see it. And if you got any questions, just stop me. We're going to cruise through to try to get as much. This is pretty dense content tonight. We talked about symptoms last time. We're not talking about that this evening. We want to talk about why the medicines work and why they cause problems. Stress diathesis model, this is sort of like that biopsycho-environmental model from Psychotic readings earlier in this semester. Just the idea that folks with schizophrenia, there's a high genetic loading, so there is some sort of propensity toward their genes manifesting with these symptoms that gets turned on, in particular in response to stress in the environment. And a lot of glucocorticoids, a lot of cortisol in the body really changes the way that cells operate. It will change the way, it will change the selection of DNA coding to pull out different RNA, and then you have cells increasing functionality, decreasing such and such. So stress is a really bad thing because chemically it changes the landscape and will change the way cells operate. It's getting different messages to do different things. That's why you often have a big stressor preceding the first psychotic break for people, and subsequent breaks as well. So you have, with the family history, you want to really pay attention for those folks. If they're in a particularly stressful financial, geographic, interpersonal, occupational, legal environment, then that's just more risk for the disease to present. From a real basic level, they find that poor maternal nutrition during pregnancy increases the risk. Maybe if mom got sick later on, and then you think about the immune inflammatory response that's triggered by infection. There's just a lot of things that just sets the stage for people maybe to develop this. I've noticed several typos in this PowerPoint, and typos are really not my style, so I apologize for those. Associated features with schizophrenia: ventricular enlargement. If there's more ventricle, if there's more empty space, then there's less brain there, so that's probably not good. Reduced hippocampal and cortical volumes, those are also indicative of prolonged exposure to stress hormones. And you may find some folks in prodromal phase of schizophrenia, maybe early illness. There may be soft signs, and you can Google soft signs. Psychotic, I believe they mentioned some too. But just some more minor, less egregious signs that may point to an eventual psychotic spectrum disorder like schizophrenia. Trouble with tracking eye movements, not necessarily nystagmus, but just difficulty with tracking and maintaining eye focus. Could be an early sign of cognitive decline. That's also true, especially with Parkinson's and with other kind of dementias that have occipital lobe involvement, which Parkinson's can sometimes look like an occipital sort of atrophy early on. Really interesting stuff. Okay, I wondered if you were referring to younger people as well. Yeah, so this isn't in the diagnostic criteria, but these are all little pieces that you're trying to pick up to put some sort of coherent piece together.
Stop it.
Absolutely. There we go. Yeah, just remember to mute your little microphones when you log in. So that'll be good. That'll be good to go. Uh-oh. Huh. Okay, there we go. Those dogs need something to do. Okay, not a problem, Sabina. So again, we didn't go over this too much last time, but you need to remember, and mainly because it'll help you make sense of the medicines and why they work and why they don't. You have positive symptoms of schizophrenia, you have negative symptoms of schizophrenia, and we talked about this last time. That positive is really too much, it's too much dopamine in the end with in the mesolimbic, you want to remember that, the mesolimbic, so from the midbrain to the sort of limbic structures, nucleus accumbens, ventral striatum, that has to do with activity and initiating movement and following through on things. So it makes sense that there would be a disruption in that process when people have disorganized behavior, or their behavior is being motivated by things that other people don't see or hear. So you have sensory misinterpretation and then behavior that isn't logical or linear or goal-directed. Mesolimbic, too much. And there is a scale that you can, it's also available on PDF, called the Positive and Negative Symptoms Scale. And that is a measure of severity of schizophrenia symptoms, the PANSS, that is used a lot in drug trials for schizophrenia. So positive and negative, because negative symptoms are also prominent in schizophrenia. So that cognitive slowing, cognitive inhibition, for lack of a better term. They don't initiate a lot of talking. They don't initiate activity. They don't initiate goals. Minimally conversant. Maybe their only speech is going to be echolalic even. There's no spontaneous speech generation at all. And then the affective component. And that is more associated with the mesocortical tract. Dopamine and norepinephrine too are responsible for prefrontal cortex kind of functioning, dorsolateral prefrontal, ventromedial prefrontal, which is associated with emotion processing, and then you have dorsolateral, where you think about abstraction and planning and sequencing and a future focus, those kinds of things. Well, if that's not working, you can see how there will be these cognitive and emotional effects, manifestations of schizophrenia, because there is inadequate dopamine activity in reasoning structures, in planning structures. So whereas maybe there's too much in the mesolimbic tract causing positive symptoms, well, why is there not enough in this other space? Shouldn't there be too much everywhere? Not necessarily. The other tracts that we really monitor with schizophrenia, one's going to be the tuberoinfundibular, which is when we say hormonal, and that's a really short tract, involved communication between your hypothalamus and the pituitary stalk. And that's when if y'all remember from last year, prolactin is one of the big hormones flying around. And the thing that turns prolactin off, because this is all about feedback mechanisms with your pituitary and hypothalamus and things, is dopamine, is also known as prolactin inhibiting factor. So if maybe you're on a antipsychotic and your dopamine receptors are being blocked, well, what might happen if dopamine's activity is antagonized, but dopamine's one of its jobs, is to turn off prolactin? What might happen? Too much. Yes. You saw where that was headed. Excellent. Y'all are a mile down the road from where I am. That's awesome. Right. Hyperprolactinemia. So you can have support of mammary gland tissue and activity, and this is very distressing, in particular with men who who are experiencing breast tissue growth and galactorrhea. But that's specifically why. And some drugs will be more likely to cause that than others. And last but not least, nigrostriatal. From the substantia nigra to the basal ganglia, that part of our brain that's trying to maintain posture at rest and really balance the job of the job of the basal ganglia is not, it's not your balance, that's your cerebellum. Really the job of it is to filter what movements are required for this purpose and what movements are not. And it is dopamine and acetylcholine working together and maintaining a balance that is tremendously more complex than researchers even thought it was probably 5 years ago. But if you disrupt the balance, because dopamine actually turns acetylcholine off in some tracks in the basal ganglia, and then acetylcholine antagonizes dopamine in a complementary track in the basal ganglia. So just a slight decrease of dopamine can have significant effects on someone's ability to be deliberate with their movements and not have any additional movements they don't want, but then actually have sufficient force of intentional movements that they do want, which makes you think of Parkinson's when someone is limited in the size of movement, the vigor with which they're walking and talking and moving. Their postural tone is weaker. They tend to take teeny steps and lean forward. It's a big problem in Parkinson's. It's a big problem with antipsychotics. We'll start with conventional, because these are the old ones. This is your Haldol. This is your Thorazine. These were the first ones because researchers, I don't know, in the 50s, 60s, realized that these medicines had a very calming effect for people and tended to decrease agitation and decrease unusual behavior in folks who didn't really have any other sort of treatment. Chlorpromazine, some of these were being researched just as hypnotics for surgeries and whatnot, and their eventual use was not the original intended use. Yeah, I thought it was post World War II, but a long time. So if too much dopamine in the mesolimbic tract causes positive symptoms, which are very distressing and potentially dangerous for the patient and other people, let's block those, and that would be great. That's really the majority of what conventional antipsychotics do, is they block D2 receptors, so the hallucinations go down, the delusions go down, the mood lability is decreased. Here, if you can see the little pointer, I don't know if you can, you have low potency, high potency. And potency just means how much drug is needed to occupy the receptors to block the dopamine receptors to see the benefit. Now, what might be good about a low potency drug, a drug that isn't aggressively blocking dopamine, is maybe you won't have as many side effects related to that dopamine blockade when you talk about the extrapyramidal side effects. When the nigrostriatal tract is being inhibited, so you have these movement problems, maybe a tremor at rest, maybe slowed movement, that kind of compression of movement and activity. A low potency drug, it isn't quite so aggressive at dopamine receptors, so you won't have the dopamine related side effects. But if you have to put a whole lot more medicine in the person, you're not only exposing them to more positive effect, but to more side effects. So I don't know if I had a picture. Yeah, we'll look at this next let's just click over to this next slide. real quick. So first generation antipsychotics, really what they do, and if you can see this little picture, probably looks like stall, doesn't it? And this is old, but it's still true. So pretend that this is a molecule of Haldol, and this is a molecule of thorazine. Big dope D2 blockade, right? So it's blocking D2 receptors, so positive symptoms go down, and that's what he's saying here. Blocks D2 receptors, mesolimbic, so positive symptoms go down. But kind of all these do is block D2. When you have these muscarinic, so that's an acetylcholine, something that would fit in an acetylcholine receptor, in a histamine receptor, that's the H, and then the alpha-1 receptor. So some first generations are more likely to have these additional side effects. The dry mouth, the blurred vision, the orthostatic hypotension, the sedation. If you're having to put a whole lot more low potency medicine in someone, then that's just all the more exposure to these other side effects causing components to the molecule. Whereas Haldol, it's really primarily just going to block D2. But if you're blocking D2 in the mesocortical pathway, well, shoot. They already don't have enough dopamine there. They're already cognitively limited. That's not good. Their affect is already flat. They're already amotivational. Well, that's not good if we're just going to block that even more. Because all those do is really block. They block D2, which is great. It reduces positive symptoms, and that's all that there was back in the day. And of course, that was better than the side effects of, than the outcome of untreated positive symptoms. And everyone is different. Not everybody experiences these side effects. And science is moving toward trying to figure out who's more prone to experiencing them, what drugs are more likely to cause them. So sticking with typical or conventional antipsychotics, you're blocking nigrostriatal tract here. So you're going to have movement problems. In some instances, especially early on in treatment, people may experience akathisia, which is not so much an inhibition of movement. It is this internal sense of restlessness, and I can't sit still. Kind of like restless legs, which I've never had. I don't know if anyone has ever had restless legs, but just full body restless leg. They can't rest. It's like they just have to move. They just have to move. They'll reposition in the chair. They'll get up and walk. They can't sit still. There's a lot of anxiety associated with this. It's very distressing to the person. It's a reason why people will stop taking the medications. And one of the worst things that can happen for a patient in need of these medications is for them to have a side effect that they want to stop. So this real significant dopamine blockade and the resulting imbalance between dopamine and acetylcholine in some folks is going to make them real restless, almost like they can't rest. And that's a lot of what the striatum and the basal ganglia system is trying to do, is regulate behavior at rest, not too much, not too little. Dystonia is a more acute response where there is just really extreme muscular rigidity, not just limited movement, but very rigid. A lot of times people will experience that not only from antipsychotics, but if you're initiating one or maybe titrating up really quickly, that puts the person at risk for that. Those are things that you wouldn't do. You wouldn't do on an outpatient basis, I would say, a very fast upward titration, because you can't monitor the person. but some antiemetics, which work, part of their mechanism of action is blocking dopamine, because dopamine is one of the signals for nausea in the brain. But medicines can go to any receptor, not necessarily the ones that you're trying to influence. So an acute dystonic reaction, which is treated if the issue is that the dopamine and acetylcholine balance in the striatum has been offset because you've lowered dopamine too aggressively, you wouldn't want to, oh gosh, we have to increase dopamine, because you might be increasing the positive symptoms as well, even though that is how restless legs are treated, with dopamine agonists, medicines that are essentially function as dopamine. But if you can't raise dopamine safely, then maybe the alternative would be, well, what if we lower the relative effect, the relative amount of acetylcholine? So that's what people do. The treatment for dystonia, for extrapyramidal side effects, in particular the Parkinsonian ones, is going to be reestablishing the acetylcholine dopamine balance by reducing acetylcholine with anticholinergics like cogentin, maybe like Benadryl. You can see that used. Akathisia may, sure, Artane. Akathisia might be benefited by anticholinergics, but it is often, that's not going to be your first line. There are a few others we're going to talk about in the atypical little section, but you may see anticholinergic used for just about as a blanket treatment for any side effect of an antipsychotic. But other options would be a beta blocker, propranolol in particular. It's very lipophilic and gets across the barrier quicker. Kind of reduces intensity of really any signaling. Low doses. Benzos, you'll see that used a lot just because sort of a blanket, it reduces intensity of any kind of neuronal firing. It'll calm everything. It'll calm the anxiety also associated with that restlessness of akathisia. But probably the best thing to do would be to switch agents. Your first choice would be, is there a comparable agent that you can switch the person to just eliminate the cause of the side effect? If not, you would try to manage with maybe propranolol, maybe a benzo, cautiously. There's going to be other rule outs for why you might not do that. Maybe an anticholinergic, or maybe something else that would make the drug sort of function like an atypical. So we'll mention that in just a little bit. The hyperprolactinemia, if you would switch agents. Tardive dyskinesia, I mean that to say there's not really a medicine to change that. But tardive dyskinesia is more of a long-term effect after long-term exposure to very potent dopamine blockade, D2 receptor blockade. And the idea being, really, if you block any receptor for long enough, those cells are going to respond by, oh, well, I guess we need more dopamine receptors, right? If all of these receptors are blocked and we're not getting enough of the downstream effect of what dopamine activity that receptor would cause, I guess we need more dopamine D2 receptors. So the body responds by increasing D2 receptors. So then you have this hypersensitivity. The person, whatever dopamine is around, is going to activate those receptors because there's just so many more receptors as a compensatory mechanism. So then you end up with and that is typically irreversible. So you end up with excess movement, kind of choreic movements, a lot of times involving the jaw, the mouth, the face, the tongue. And that's why the importance of monitoring with the AIMS, because if you can catch those extrapyramidal side effects early, if you can manage them, if you can catch the tardive symptoms as soon as possible and switch to a different agent, then that's what you want to do, knowing that this is a long-term, essentially, adaptation of the organism of the person that doesn't go away. And it can eventually affect, you can imagine the social impact of that, the impairment from that, but it can also eventually compromise chewing and swallowing. So this is significant. But you mostly see this after people have been chronically exposed to real potent D2 blockers. Neuroleptic malignant syndrome. Yeah, there is a new medicine for tardive dyskinesia that is being advertised at the VA right now that is supposed to be kind of pro-dopaminergic to address these symptoms without a lot of side effects. I don't know a whole lot about it. I've never written it. I don't know anyone at my little clinic who has as well. But yes, this is, I guess now that medicines have been around, even the atypicals have been around long enough, and people are successful with treatment, that folks are being exposed to them longer, so the risk of tardive dyskinesia is just greater. It's now something that we need to try to find a way to address. But I would like to know more about it. It's just not something that I have familiarity with in my practice there. I don't know if you can even order it. But neuroleptic malignant syndrome, which looks an awful lot like serotonin syndrome. So if you're starting someone on a conventional, if you're increasing the dose a good bit, Brenda's right. Yes, we do. Neuroleptic malignant syndrome, dopamine goes down, then compensatorily serotonin goes up, and that can result in something that looks a lot like serotonin syndrome. High temperature, agitation, anxiety, restlessness, tremor that looks like real firm, lockdown. I think last week I said, this is very rare, this doesn't happen very much, but I think some folks who work inpatient have seen it maybe even more than one time. So you'd want to discontinue. This is going to be something that, if you catch it early, you DC the medicine and you do supportive care. There are some medicines to reverse serotonin syndrome. So again, it's not just that it's not enough dopamine, it's the imbalance that it causes. When you get one thing off balance, then everything else is off balance. So those are conventionals. They block D2 receptors. They help positive symptoms. They cause all these side effects. And then something else was invented. The atypicals, the second generations, and this is standard now. So it's going to improve. If you block D2 receptors in all tracks, including mesolimbic, then that means, okay, the positive symptoms will be better. Well, that's great. But is there a way to not make all the other stuff worse too, like the cognitive symptoms in that mesocortical tract? You don't want to just block more dopamine. You will further compromise initiation and motivation and attention and abstraction, and that's not a good thing. So that little oh no, we don't have a picture of that one, I don't think. Still has tons of pictures. By also blocking serotonin 2A receptors, because that's what makes an atypical, the newer generation, well, as of, 25 plus years ago. Serotonin, we've talked before about how serotonin can kind of turn dopamine off, and this really has to do with serotonin 2A receptors on dopamine axon terminals. So that's where dopamine's trying to get released from somewhere, but it has some autoreceptors, meaning if it's filled, then less activity. And that's what serotonin 2A does. If serotonin lands on a 2A receptor, then it lowers the gate and it says, nope, no more dopamine can be released. If you block that, then the gate can't be lowered and dopamine can be released. So blocking 5-HT2A means maybe a little bit more dopamine is getting available into the synapse. So while you're blocking where the dopamine's trying to go, you're making sure there's a little bit extra dopamine floating around. So a little bit of dopamine can trickle through. That's great. Because if blocking dopamine everywhere causes all these side effects, it will be helpful to have just a little bit extra dopamine available to try to prevent the excess prolactin, to try to prevent maybe some of those Parkinsonism symptoms, to maybe let cognition improve a little bit. There are very few 5-HT2A receptors in the mesolimbic tract. So while 2A antagonism lets a little dopamine out, those positive symptoms won't be increased by this because this receptor doesn't have a lot of influence in the mesolimbic tract anyway. So you're not accidentally increasing dopamine where you don't want it to be. You're mainly increasing it where you do. And then atypicals have varying affinity for histamine and acetylcholine receptors. And that's really important when you're choosing a medicine. So talking medicine. Someone with positive symptoms needs about 60%, and they can tell because they do brain scans and they do blood work when they're monitoring these medicines, and it's really phenomenal, the specificity. But you need about 60% of a person's dopamine receptors to be blocked to see a treatment effect. So if you're hovering around 30% of them are blocked or 50% of them are blocked, they may have slim to no antipsychotic benefits from the medicine. So don't hesitate to increase the dose. You might start lower, and all these drugs have recommended starting points, but go ahead and increase to the range where that drug is going to get you the treatment effect. Because if you don't get high enough, you're kind of spinning your wheels, and the patient's not going to get better. So you need 60% for a treatment effect, but look, if you overshoot and now you have 70% dopamine receptors are occupied, well, that's when the prolactin increase starts happening. A little bit more receptors occupied, well, shoot, well, that's where our movement disorder symptoms begin. Yikes. So there's a window where the person gets a benefit, but they're not exposed to the side effects and are more likely to continue the medicine. So just some concepts for how we can get a good treatment effect but minimize the adverse effects has to do with the drug's attractiveness to the receptor. How long will it take to see it in a patient? By the time you get to that treatment effect, you would expect to see benefits pretty soon. By the time you get up to that dose, maybe 4 to 6 milligrams of Risperdal or 600 milligrams of Seroquel, whatever the relative dose is. But they'll probably be really sleepy for the first few days. But if you get them there, they should really see significant symptom improvement, certainly within a week. Hopefully less, if it's the right medicine. And if you're looking at increasing, and that's kind of going from start to finish, but if you're looking at really aggressively up titrating things, then you would want the person to be monitored on an inpatient basis. And really, schizophrenia acutely is an inpatient issue. It's inpatient. The drug's attractiveness to the theory, up to the theory, you can tell where I'm looking at, to the receptor, makes a big difference. Because ideally, a medication would block the receptor, block the dopamine receptor, inhibiting the activity, but then maybe hop off of that receptor. Because the longer D2 is blocked, the more risk of the side effects. And what the research indicates is that the drug doesn't have to be on the receptor permanently, and of course it won't be, but it doesn't need to be there for long to cause downstream therapeutic effects, to change how that cell influences the next cell down the road. And when you look at just comparing those times, is that a molecule of Haldol will stay on a D2 receptor 30 minutes, whereas Clozaril, in atypical, doesn't stay on there very long. Clozaril also doesn't have as many extrapyramidal side effects as a conventional, and that's probably why. Another important concept that I want y'all to know when you're looking through Stahl's book at the pictures where it shows relative receptor affinity, it'll be that row of boxes that are different sizes and different colors. D2 will be here, and then it'll show you all the other receptors that drug has affinity for, that drug will land on and stick on, is this dissociation constant, or KD, dissociation constant. How much drug in the system is needed to occupy half of the D2 receptors? And what we're wanting to do with these drugs is to block dopamine. So what really matters is the drug, is it more attracted to D2 receptors than the dopamine? Is it less attracted to the D2 receptors than dopamine? Okay. If a drug, and we have 3 examples right here. So dopamine, on the scale of dissociation constant, is about a 1.75. So dopamine is almost about, and a way to look at it is 1 to 1. If it's a 1, then it's about as attracted to that receptor as whatever that receptor is designed to receive. So dopamine, it's a 1.75. That's about a 1. Dopamine likes dopamine receptors. That makes sense. It's about a 1. Risperdal, it likes dopamine receptors even more than dopamine does. It's almost like this is how much dopamine you would need to keep about half the dopamine receptors occupied. Risperdal likes dopamine receptors even more than that. Haldol likes dopamine receptors even more than that, whereas Seroquel, you got to put a whole lot more Seroquel in the system than you do Risperdal to block the receptors to get a treatment effect. I want you to know, Deborah, the concept of dissociation constants, because that is what Stahl is trying to show you in those pictures. When he says this drug likes alpha-1 receptors even more than it likes dopamine, whereas this drug doesn't like M3 muscarinic receptors as much as dopamine. That's what he's trying to convey. That if a drug is really high affinity for histamine receptors, even more than its affinity for dopamine receptors, wow, then it's probably, that's a pretty strongly antihistaminic drug. This is largely related to potency, yes, because if a little bit of a drug goes a long way, it's real potent. Probably because that drug really likes the receptors and it gets on there and it sticks to it. Risperidol is a higher potency drug than Seroquel is. You need relatively this much more Seroquel to do about what that amount of Risperidol would do. And we're talking about just sticking to the receptors. We don't mean treatment outcome. You would never give someone, well, actually, that's actually pretty close to the truth when I think about it. Because, 4 to 6 milligrams of Risperidol kind of sort of correlates to about 600 to 800 milligrams of Seroquel. So, and don't use this to calculate what drugs you're going to start people at. We're just trying to convey, from a really chemical standpoint, why high potency drugs, a little bit, sticks, has a lot of effect. Seroquel, you got to crank the dose up a good bit higher. Whereas, Geodon's maybe kind of somewhere in the middle. Zyprexa, lower to the middle. And if a drug is even more attracted to histamine than it is dopamine, then as you up the dose to get the antipsychotic effect, you're going to up the antihistaminic and the anticholinergic and the antiadrenergic. La 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 la. Something neat to look in those pictures is a drug's relative affinity for D2 versus the 5-HT2A. Because remember, it's that serotonin 2A antagonism that helps the drug not cause the side effects of prolactin and movement. If you're releasing a little more dopamine in the frontal cortex, then that serotonin 2A antagonism may actually help cognition and things in the mesocortical tract. So again, you have these drugs that are leaving a little bit of dopamine to leak out. It should protect the person from long-term exposure that looks like tardive dyskinesia, because there is a little dopamine available to work and prevent side effects. Doesn't mean it's impossible, so you still want to monitor for movement disorders. You want to do your AIMS every 3 to 6 months. Because it's still possible, because you're still blocking D2 receptors. It's interesting, too, that a lot of these atypicals block, they block all kinds of receptors. That's why there's so many boxes in Stahl's books when he's showing you the receptor affinity for those drugs. But if they're blocking acetylcholine receptors, well, maybe that's because the whole idea behind the movement disorder is an imbalance between dopamine and acetylcholine. Well, some of these drugs kind of block acetylcholine receptors automatically. That's also going to be a reason why you have fewer of those movement disorder symptoms with atypicals. Something that Abilify doesn't do is have activity at acetylcholine receptors. And Abilify is notorious for causing akathisia. So, because that somewhat protective mechanism isn't built into that drug. And it's a very potent partial agonist. I mean, potent. Right, low weight gain. And that's something that we wanted to talk about. I'm glad, Kelly Hamill, glad you brought that up. Varying degrees of sedation, orthostasis, and weight gain. And here we're really talking about all the different atypicals. How attracted are they to H1, alpha-1, and muscarinic anticholinergic receptors? Because the problem is That while these drugs are helpful in reducing positive symptoms, not as many movement side effects, lower chance of tardive dyskinesia down the road, tons of metabolic risks associated with them. I mean, almost unavoidably. And that relates to those receptors that they also block. That alpha-1 receptors activation, not blocking, but alpha-1 receptors are partially responsible for the pancreatic release of insulin. You actually have noradrenergic and anticholinergic innervation to the pancreas to try to signal release insulin versus don't release insulin. And when you're blocking H1 signaling and blocking acetylcholine muscarinic signaling to the pancreas, you have reduced release of insulin. That's a problem, because then these folks have sugar with nowhere to put it. So in a way, they contribute to glucose intolerance. So that's a problem. M3 muscarinic, which is an it's an acetylcholine receptor, is involved in satiety. So you have muscarinic receptors being involved in glucose intolerance. You also have it when it is blocked. It is harder for the person to perceive that they are full. H1 receptors, it is harder for the person to perceive that they are full. In studies where they knock out H1 receptors in these poor mice, the mice just eat and eat and eat, and there's no way to turn it off. So you may have increased feeding behavior, reduced recognition that the person is full, reduced insulin secretion. None of these are intended effects of the medicine. The molecule just happens to fit in those receptors. Orthostasis, alpha-1 as well on smooth muscle, you block that, and then you have orthostasis. We knew that already, but these receptors are involved in other functions as well related to feeding. It's interesting, too, that the release of renin, so kind of initiating that renin-angiotensin system for blood pressure regulation and increase, that is also influenced by altering alpha-1 and M3 muscarinic receptors. So these atypicals are complicating the the organism's attempt to maintain their own blood pressure. And that's what you see for folks who are on these drugs, is weight goes up and sugar goes up and blood pressure goes up. Maybe not only because of the person's weight increase. So those are the real side effects you're monitoring. And if you look at the different drugs in stall, you can see, oh, well, this one, maybe that's why this one is more sedating than that one. Maybe that's why that one causes more weight gain than others. Geodon is known, it's infamous for the QT elongation, because it'll increase it maybe 15 to 20. If you look at studies, it'll increase someone's QT interval from maybe 15 to 20 milliseconds. So if the person's borderline, you wouldn't want them to be on Geodon at all. If you do EKG and they're young and otherwise healthy, then sure, you could do that. Because some other benefits to Geodon, it's indicated for bipolar as well as for schizophrenia, is it's an atypical, so we know a couple of the things that it does. It's more weight neutral. It's not as sedating, so maybe it less antihistaminic activity. But it also inhibits the reuptake of serotonin and norepinephrine, kind of like an SNRI antidepressant. And this drug is more so known for maybe even more so above and beyond improving the cognitive symptoms of schizophrenia, which is norepinephrine, particularly in the prefrontal cortex. If you can enhance norepinephrine there, you may improve cognition and attention and planning, those kinds of things. So that's great. Just another sort of special thing about Geodon. A little more weight neutral. Zyprexa is the most metabolically concerning, and it has really, really, really strong antagonism at alpha 1, H1, and 5-HT2C. So serotonin 2C, not 2A, because that's our good dopamine releasing side effect preventing receptor, but serotonin 2C is also intimately involved in satiety and feeding. So when you block it, people want to eat more. So that's Zyprexa is really a combo drug. Any of the individual mechanisms that would make you want to gain weight, it does. Surprise, surprise. It's the worst for weight gain. Risperdal and its what's the word? Its protege, its child, Invega. Those maybe not so much of maybe not as much metabolic concerns, but it's a pretty potent D2 antagonist compared to the others. Like we just showed, it's even more attracted to dopamine receptors than dopamine is. So you may be more likely to have that prolactin release because of that. And you see that a lot with Risperdal, patients on Risperdal. Some other drugs, Safras or acenapine, it tends to be real sedating. It has a lot of H1 antagonism, not as much anticholinergic activity. So maybe that it tends to be a little more weight neutral. Fanapt or iloperidone. That's interesting. Acenapine, you think those peens versus the dones. Not as weight neutral. I don't know if anybody here works somewhere that you use a good bit of Safras or Fanapt. Those are probably some of the newer atypicals other than, I'm trying to think if there's anything in the peen or done family. Seroquel is real strongly antihistaminic, pretty strongly anticholinergic. So you'd be concerned about weight gain and sedation with that because it blocks alpha 1, it blocks H1. And what seems to be the case is that in combination, if multiple receptors are being blocked by a drug, then it's almost like the person can't overcome it and they succumb to the metabolic side effects. Whereas if it's just antihistaminic, antiadrenergic, but leaves acetylcholine alone, then maybe it won't have the weight gain. Plus, they're finding too that some folks are genetically predisposed to gain weight. And it's often people who are lower BMI when they started the atypical. Yeah, Seroquel, real antihistaminic. Interesting about Seroquel is it has an active metabolite that is also a norepinephrine reuptake inhibitor. Because you think about Seroquel, it's helpful for anxiety, it's helpful for sleep. Well, it has a metabolite that is pretty good at affecting, regulating norepinephrine. Kind of like Effexor that we use for panic and Cymbalta that we use for GAD. If the medicine helps and the person will stay on it, they can have a great outcome. But a lot of people will quit taking it because the side effects are so awful. They're tired, they're gaining weight. It makes them feel restless. I wouldn't want to take that either. Management of atypicals. This is real basic stuff. You want to get labs annually after they've been stable for, if you get labs when you start, you would want to get labs at about 3 months. You may want to get them one more time 3 months after that, but if they're not having a significant increase, then you can push it out. But you certainly want to get labs at least every year for someone who's on long term. because of the risks. Fasting blood glucose. I mean, your metabolics, you get a glucose, but oh no, not a problem. I'm sure y'all are thinking, I wouldn't do that. I would get an A1C. And you would be right. But it's really about you're trying to catch if they're having an increase early in treatment, but if it's pretty steady, then you can push it out to annually. Let's say you get, you're good, 6 months later it's the same. Okay, we're not going to do this again for a year. Unless they come in and their weight's totally different, and then you're going to suspect. That something's up. This is real quick. You can just look at the slide. I really don't have anything to add to this right now because this is child specific, but there are medications indicated for psychotic disorders in kids. Remember, sometimes it'll show up 13, 15, 17. That's young. Yeah, EKG ought to be on there. Technically, you should order an EKG before you start any atypical. Technically, you would order it. And if you look at the FDA inserts, before you start any atypical. That doesn't happen. You really would want to get it, like Tracy's saying, before you go to Geodon. Because if you have an option, you can't justify Geodon if their EKG is borderline and you have another option. So, yeah, definitely with Geodon. But look, these 3 medicines are indicated even for kids, 13 and up. That's young, but psychotic disorders can present, and prodromally can present in kids this young. It's rare. I think we said less than 10% of people who end up with schizophrenia had it this. Catching early and intervening early, and UAB has a first episode clinic, and I'd be interested for what else. Yeah, from what you learned from that. That's cool. Fish oil, CBT. And there is evidence now that cognitive therapy is actually helpful for schizophrenia when historically it was not believed to be so. So we'll go through this real quick and then we'll be done so we don't keep y'all late. But how do you end up with too much dopamine in one place and not enough dopamine in another place? Why does too much dopamine cause positive symptoms, but it doesn't but then you have all these negative symptoms? And you block dopamine and the positive symptoms get better. The negative symptoms get worse. Antipsychotics don't really help the negative symptoms. And the newer idea is that it's not an issue of just too much dopamine. It's a precursor that actually causes too much in the mesolimbic tract and not enough back into the mesocortical tract. And glutamate, which is the primary excitatory neurotransmitter in the brain, that there seems to be a problem with NMDA receptors, so a glutamate receptor, not able to turn GABA on where it should. So they have figured out, they're theorizing a step prior to the too much dopamine here, not enough dopamine there, and it has to do with glutamate not activating GABA receptors appropriately. And that makes sense because if PCP, the drug, is a real potent glutamate blocker, and folks with PCP, not only do they experience the hallucinations and the mood lability and what looks like positive symptoms, they will have negative symptoms too. And when you look in Stahl, this is just a simplification of what he's trying to say, that the same malfunction is what causes too much dopamine in the mesolimbic tract and not enough dopamine making it back up to the cortex to help with planning and initiation and cognition. The idea being, and he has these little pictures on that little page, that you essentially have a GABA interneuron. And its job, a GABA interneuron is just a little inhibitory gate in between two other neurons. So the problem is that in the cortex, GABA is not able to turn off the signal going down into the mesolimbic tract. So whereas you have too much glutamate making its way down into the ventral tegmental area, down into the midbrain where dopamine starts. You have too much dopamine making it down there because that GABA interneuron can't turn the glutamate off. Glutamate just means go. So you have too much glutamate heading to the midbrain saying, go, dopamine, go. Whereas, ideally, that GABA interneuron, GABA being inhibitory, would say, whoa, 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 whoa. Quit turning on all this dopamine. Quit turning it on. That doesn't happen because the GABA neuron isn't activated effectively. So it's just not turning it off. That's why too much dopamine is being kicked out from the midbrain. It's not being turned off. It's getting way too much signal to go. Well, why then shouldn't we have too much dopamine in the cortex? Shouldn't we have great cognition and great thinking? No. When too much go signal, too much glutamate is making its way down into the midbrain, too much. The problem is that it's not directly turning on dopamine to head back to the cortex. It's unfortunately running into a GABA interneuron. So you have way too much go signal hitting a GABA neuron. And if you overstimulate a GABA neuron, you're going to have a lot of inhibition because that's what GABA does. So the idea being the kink in the problem is that in the mesocortical tract, there's way too much go signal making it to the midbrain, but it's landing on a stop signal. It's landing on a GABA interneuron, which is inhibiting any dopamine from making it back to the cortex. So it's, if only that glutamate receptor on that initial GABA neuron worked, it would regulate the amount of signal making it to the midbrain. But glutamate can't turn GABA on, so too much signal makes it down. Therein lies the problem. So it would be great if you could inhibit dopamine in the mesolimbic tract. You could boost dopamine in the mesocortical tract. And unfortunately, one of the best ways to do that, one of the most effective antipsychotics is clozaril. An interesting little tidbit about NMDA receptors for glutamate is that they need glycine to be fully functional. Glycine just being a little amino acid that, kind of like the way that a benzo landing on a GABA receptor just helps GABA work even better. Similar concept. So then you look at clozaril. Clozaril is not used much because of the risk for agranulocytosis. But clozaril blocks D2. Positive symptoms go away. Serotonin 2A receptors, limiting the side effects. It doesn't stick. It's not real sticky on the receptors. It's a dissociation constant is pretty high, so it's fast off. And it also functions as a glycine reuptake inhibitor. So holy moly. It's going to, It's going to help the glutamate at that under-functioning receptor work even better and kind of fix the problem upstream. Prevent all that glutamate from turning things on way too much. Yeah, ketamine, Tracy's mentioning ketamine. That's showing promise in a lot of, even in some PTSD research. Right. So that's pretty cool. That's neat that y'all do that. So that all being said, treatment goals, safety. Is the person, are they safe? Do they have intact reality testing? Are they taking care of themselves? If not, they need inpatient care. They need acute stabilization with atypicals, maybe with other medicines, maybe with benzos, depending on how agitated they are. And the plan, the goal is get them on a medicine that they can tolerate. I think we talked about long-acting injectables last time. Cognitive therapy is actually showing symptom improvement, not only for patients but for families, and reduce risk of relapse down the road. You want to monitor for side effects as early as you can. Different levels of treatment with this. Probably the main things that you'll need to know going forward on the exam. We posted a study template in the module, but you'll want to know about symptoms to tell the disorders apart, obviously. Medications, side effects, any notable behavioral treatments, any notable screening measures. Backtrack real quick on clozaril. The reason why you don't see clozaril used as much is because it causes some sort of toxic. There's some kind of metabolite of it that is toxic to white blood cells. So I mentioned real briefly agranulocytosis. There are some people who do really well on this medicine, but you have to monitor, get a CBC every week for the first 6 months of treatment to monitor white count. And then after 6 months, you're going to every other week. So you can imagine if someone's not adherent to the monitoring, this wouldn't be safe for them. So for a patient who is maybe in a residential kind of setting where there's closer monitoring and making sure that labs are being done, great. Because again, for those different reasons, it can be really helpful for negative and positive symptoms. But the risk of that is too high. People die if they get this, if they take this medication and they're not appropriately monitored. Spooky stuff. But yeah, the current understanding is that it is toxic to the intracellular functioning of white cells in particular. So the person ends up very sick. Best outcome if no psychosis for 3 years after the first breakthrough. So you try to get people on a steady level of medication. Absolutely. And folks, a lot of times they'll leave the hospital, miss a few doses, and they'll have a relapse. Cigarette smoking will reduce the effectiveness of clozaril and Zyprexa because smoked tobacco induces 3A4, not 3A4, I have that stuck on my brain, 1A2, apologize. And smoking is so popular because folks are trying to correct this dopamine, this lack of dopamine prefrontally from the negative symptoms, and cigarette smoking can enhance that a little bit, so there's a big tendency to smoke. People trying to regulate their own physiology. But yeah, if people have much better outcomes the longer they can stay well. And it was always just so sad to me when people would start getting sick. because you knew they were going to be sick for a while. Recovery was going to be, challenging for them. It was always just sad to me. Yeah, marijuana, which can increase the availability of dopamine in some locations. Marijuana's a problem. Cocaine's a problem. Meth's a problem. So thankfully, there are really good drugs to help these folks do well. Thankfully. Marijuana is worse than people think. Pretty hot button topic, I'd say. Okay, we've kept y'all over. I do apologize. This was just a lot of pretty heavy material. Please email us with questions about the content or about the exam coming up. Any issues like that, don't hesitate to let us know. We'll try to clear it up for y'all. We appreciate you being here this evening. And that is all I got. So any quick questions or nope? Good. Ha ha ha. Let's shut it down. And y'all have a great, great evening.